Hello again to everyone, and thank you for joining us for today's webinar. We'll be covering how the Saving Access to Lab Services Act would fix some of the flaws that have been introduced to clinical lab fee schedule repricing under PAMA the last half decade plus. My name is Alex Mitchell, and I'm a communications manager for the Lighthouse marketing team. And I'm going to quickly introduce our expert speakers today. We have Erin Morton, a partner with CRD Associates, a Washington, D.C.-based lobbying firm, and Ann Lambrix, Vice President of RCM Consulting for us here at Lighthouse. A little bit of background on both of our speakers. Erin Will Morton joined CRD Associates in October 2017, bringing with her a decade of experience in global and domestic health policy. As part of her role with CRD, Erin serves as a lobbyist for the National Independent Laboratory Association, NILA, helping to advocate for and advance legislative lab interests. Erin's practice areas include domestic and international medical research and development funding, Medicare reimbursement, clinical lab issues, coalition management, and patient advocacy training. Erin represents clients in the complicated world of Medicare reimbursement and has extensive experience engaging federal agencies and Congress. She holds a master's degree in American government from Johns Hopkins and a bachelor's in political science from Dickinson College. Ann Lambrix, again, serves as Lighthouse's VP of RCM Consulting and heads up the division's day-to-day operations. With more than 20 years in medical insurance and billing industry, her experience provides for an insightful analysis of revenue cycle and payer trends impacting reimbursement. Ms. Lambrix also holds an MSJ in Health and Hospital Law. Huge thank you to both of them for joining us today. We greatly appreciate their time and willingness to share their expertise with our audience. And with that, I'm going to go ahead and turn things over to Erin. PAMA has definitely been a huge thorn in the side of our laboratory clients for some time now, and we're really eager to hear a little bit more about how SALSA can help amend some of those issues.
Thanks, Alex. Thanks for having me here today to talk with everybody a little bit about SALSA and some potential opportunities to improve PAMA as we move forward. As Alex mentioned, I'm going to talk a little bit about where we are currently with PAMA, some of the potential opportunities down the road with SALSA, or the Saving Access to Laboratory Services Act. That's probably the last time I'll say the full name, but we refer to it as SALSA, which is a great name as we're advocating for the legislation on Capitol Hill. And then I'll talk a little bit at the end of my presentation just about how you all could get involved and how individual labs can help us advocate for the passage of SALSA in Congress. So I'm going to start with just a quick recap of where we are today. We're all familiar with PAMA and the cuts that have been implemented as a result of PAMA. But as a refresher, it was legislation, the Protecting Access to Medicare Act, that passed in 2014 and resulted in pretty significant rate cuts to the clinical lab fee schedule that went into effect in 2018. And of course, there was not an across-the-board cut to all test codes, but rather each code was examined individually, and established new rates were then published in 2017 and went into effect in 2018. Unfortunately, the data collected from labs was really not representative of the entire laboratory industry. There was overrepresentation by the large national labs. About 90% of the data that was collected was from independent labs, despite them only really being about 50% of the volume of the CLFS. So that drastically drove rates down. Test codes were cut anywhere from 30 to 60%. And while there was a phase-in of those cuts over time, the impact on clinical labs, as you all know, was pretty significant. So we had 3 years of 10% cuts in 2018, 2019, and 2020. Fortunately, in 2021 and 2022, the cuts were frozen by Congress. This was really as a result of advocacy from the laboratory community pushing back on the impact that COVID was having on labs and the challenges that labs were facing with additional cuts coming down the road as they were ramping up to try to prepare for and respond to the pandemic. However, 15% cuts are scheduled to go into effect in 2023 if Congress doesn't take any additional action. So that's kind of the key component there, because we're going to talk about some potential changes to that with SALSA. And then, of course, the next round of data reporting is also scheduled to go into effect in January 2023, absent any congressional action. So let's talk a little bit about SALSA. The bill numbers are there at the top of the slide. In the House, it's HR 8188, and in the Senate, it's S4449. And so let's talk a little bit about what is in the legislation, what changes it would make to PAMA. I think important to note, the bill is bipartisan, so means there's Democrats and Republicans on the bill, and it's bicameral, so that's why it has a House and a Senate number. This is a really good place for a piece of legislation to start. Passing legislation in the current political environment is challenging, and so that'll be one of the things that we can talk a little bit more about at the end, and if there are questions, as we talk about some of the advocacy that's underway to really try to get SALSA passed before the end of the year. So let's put that aside for a minute and talk a little bit about what the bill does, and then we'll certainly come back to the likelihood of it passing and maybe some of those challenges. So it would be permanent reform to the clinical lab fee schedule. It's not just a short-term fix. It requires that private payer data would be reported from a statistically valid sample, and those are key words there, of applicable laboratories for what they're defining as widely available clinical diagnostic tests. And widely available tests are defined as tests that cost over $1,000 and are offered by more than 100 providers, and that's providers as defined by NPI number. Advanced diagnostic laboratory tests, which was a definition we're familiar with from PAMA, and any tests that are not fitting that definition of widely available tests would retain their current PAMA requirement for reporting, where all labs would be required to report. So those are set aside from the new regulations or definitions under SALSA, and we're focused primarily on those widely available clinical diagnostic tests, which is the majority of the clinical lab fee schedule. First reporting period would be in 2026 under the new statute, assuming it passes this year. And we're going to look at a comparison on the next slide to talk a little bit more about the dates and the cuts within each year that would be possible. Reporting is every 4 years rather than every 3 years as it is currently under PAMA. A couple of key changes in addition to that statistically valid sampling of the data that's actually going to be collected. So Medicaid managed care contracts are being excluded from the applicable data that would need to be reported. So that's good news, since those are generally driving rates down. And then we are no longer using the majority of Medicare definition in determining an applicable laboratory. And so they're going to be defined by NPI number, and you don't have to meet that 50% threshold anymore. And this is, of course, the goal of getting a widely available sample of the entire clinical laboratory industry. The legislation actually does specifically call out that it is hospital labs, independent labs, and physician office labs that would be required to report. So again, trying to move away from that large sampling of just independent labs in the original PAMA definition. The low volume threshold remains the same as it was under PAMA. I don't think that impacts a lot of labs, but some very small physician office labs potentially impacted by that low volume threshold, which is the same as it is under PAMA. So I think overall, there's a lot of hope that SALSA will have a lot of positive impacts on both the administrative burden that PAMA caused for labs to report all of your test rates every 3 years. Certainly moving to 4 years is better, but that statistically valid sample is really, really important, and that's really the crux of what SALSA does. And that's really looking at choosing a specific number of test codes that would be required to be reported, within each reporting cycle. So reporting won't be based on lab, but rather on test code. So labs would be notified ahead of the reporting period what test codes they need to report on. And then that small sample will be extrapolated out to accurately match the clinical lab industry. So whatever percent of the market is independent hospital and physician office labs would be the calculation that would go into extrapolating that data out to match that full sample. I'm going to talk a little bit on the next slide about sort of what this means, PAMA current law compared to SALSA. This is a little complicated, but I'm going to walk through it, and I think this is the best way I've found to kind of map out what those key differences are. So under current law, PAMA on the left-hand side in purple, you'll see in 2023, highlighted in purple, is our next round of data reporting. And that would be based on data that was collected in 2019, because that's the current data collection period under PAMA. And that would derive new rates that would go into effect in 2024. And so where you see the 2024 line, those rates are derived from the data reporting period at the beginning of next year. And then let's talk a little bit about the max cuts. So as I mentioned, right, PAMA had a phased in approach for the maximum amount that any particular test code could be cut in any given year. It was 10% for the first 3 years of PAMA implementation. It then goes up to 15%, which is why we're facing a potential 15% cut across certain codes in 2023. And then in 2026, after those 3 years of 15% cuts under PAMA, there is no cap on the amount that any particular test code could be cut. So you see those listed as any. Under SALSA, so these are estimates based on if SALSA were to pass this year. Certainly, if it doesn't pass this year, you could see these timelines changing or getting bumped out into the future. So 2022 remains status quo because we're operating under current law, so nothing there. In 2023, the legislation requires that there's no cut to the clinical lab fee schedule. So this is an added bonus. While we're working to implement SALSA, there would be no cuts in 2023. It also then pretty significantly changes what those maximum cuts could be. And this was something that as NILA and other organizations were advocating with Congress to write the legislation and to try to protect labs. One of the things that was really crucial was limiting those cuts, the cap on those cuts. And so you'll see that the phase-in is much more gradual than under PAMA. There's a potential 2.5% maximum cut, which then goes to 5%. And those 5% remain in the statute permanently, so they don't disappear like they did under PAMA. There's something new under SALSA that didn't exist under PAMA, which is a maximum increase that any one test code could see in a given year. And this was something put in place to help balance the inevitable cost that this legislation will have to the government. And certainly the goal in reforming PAMA is to get rates back to where we feel like they should be to reflect true market value. And that's going to have a significant cost to the government. And so these maximum increases were a way to protect the Medicare program from those potential increases, and sort of a deal-making scenario where we agreed to, that potential cap on increases, really more focused on not having such significant decreases. So the maximum amount that any test code could increase starts at 2.5%, gradually works its way up to 5%, so that by 2027, which is really the first year that new rates would go into effect under SALSA, as you'll see highlighted in red there, data collection begins in 2026, but the new rates would go into effect in 2027, and that would be based on the data collection period in January of 2025, which would be reported to CMS in 2026, and then CMS would derive those new rates and they would go into effect in 2027. And then that 5% increase sticks there permanently. So no test code could change more than 5% in any given year starting in 2027. So we can come back to those numbers if folks have questions or want to dive in anywhere, but I do want to talk a little bit about where grassroots matters and what you can be doing as laboratories. So as Alex mentioned, I work with NILA, the National Independent Laboratory Association, which represents regional and community clinical laboratories. And we're working really hard through the last couple of months of this year, both my colleagues in Washington, but also NILA members doing outreach and grassroots activities to try to get Congress to pass SALSA before the end of the year. We would love to have additional help. We always welcome other labs joining the fight. Certainly NILA is not alone in this advocacy effort. We're working very closely with our colleagues in other laboratory associations in Washington. And we encourage all of you to reach out to your members of Congress. It's a relatively simple phone call, letter, or email, and ask them to co-sponsor SALSA. They'll ask you for the bill numbers, so I recommend keeping those handy. You can tell them, quickly what it does and why it's important to your lab. There are talking points on the NILA website, which is highlighted here, and the website address is below. If you're interested in using those talking points to help frame your conversations, and you can use them in your outreach, you can use them to craft a letter, you can use them just in a phone call or in an email. NILA is one of many associations that has just recently signed on to a letter in support of SALSA to House and Senate leadership advocating for the swift passage of SALSA before the end of this calendar year. That letter will be published sometime next week once Congress is back in session after the August recess. We'll send that to the Hill, and then we'll publish that letter on the NILA website. I'm happy to make sure Alex has a copy of that and we can circulate that to all of you who'd be interested in seeing that letter, and most importantly in reiterating a similar letter of your own to Congress. I think the more they hear from labs about the impact that PAMA is having on your lab and the ways that SALSA could improve your life and the patients that you serve, the better. So volume matters in this. And I think I'll just say quickly before I turn it over to Anne, there's a lot on Congress's plate before the end of this year, and I promise to give a little bit of the political window into kind of the chances of this moving forward this year. I think Congress has been gone on recess for the last couple of weeks for August. They come back next week after Labor Day. And they've got a lot of things they've got to tackle immediately. They've got to tackle FDA reauthorization, which we talked about the last time I joined for a Lighthouse webinar. They've got to tackle funding for the federal government. Appropriations expire on September 30th. And that period of time is going to be relatively busy. I don't necessarily see that as the window of opportunity for SALSA before Congress then leaves again for most of October to head home to campaign. So most of October in an election year is spent on the campaign trail. And then they will come back after the election in the middle of November and work towards the last couple of pieces of legislation that need to be done by the end of the year. That's usually what we call a year-end package. And so that is really the target that we're looking at for potentially passing SALSA or including it in that. It was in last year's year-end legislation that we were able to get the additional delay for the 2022 fee schedule, as well as another delay in reporting. So, that's really the opportunity for Medicare fixes and things to move forward. Our legislation does have a cost associated with it, though. I mentioned that earlier. And so there'll be some, tough conversations about how to, quote, pay for, which is the term Congress uses when something costs the government money, this permanent fix. It's not our business to suggest ways that Congress pay for it. Our job is to advocate for why it's important and why we need it to happen. And so we've steered clear of recommending any potential cost savings elsewhere, and that's not something that we'll do, nor do we see that as our role. But really advocating for, look, this is a permanent fix, and this needs to happen, this year to save the clinical laboratory infrastructure around the country. And I think we've got some really good messaging around that, especially coming out of the COVID-19 pandemic and then facing another pandemic with monkeypox, and the role that labs play in our public health and healthcare infrastructure is not going unnoticed. And so we're using all of those talking points to really help frame the message of why this is so important. So I will pause there. Alex, I'm happy to take questions or turn it over to Anne and take questions at the end.
Yeah, thank you so much, Erin. And I think we will turn it over to Anne here. I just have one question that's been upvoted a few times that I'd like you to touch on before we transition. But Teresa Williams asked, can you clarify a bit on a widely available test as one being over $1,000, since most lab tests are paid under $1,000? You're not talking about the price of the individual test there, right?
I am talking about the price of an individual test. So okay. If it's a widely available test, it would be, it's under, oh my goodness, it's under $1,000. No wonder everybody's so confused, Alex.
That's okay. I missed that too during our edits, so my mistake.
It's under $1,000 and more than 100 providers. So it is the bulk of the fee schedule. I'm so sorry for that typo.
And I just want to confirm, it is the Medicare reimbursement under $1,000, not what the lab is charging. Correct? Yes. Okay. I just wanted to confirm that because the charge you could charge under $1,000 for everything, and so again, I just wanted to make sure everybody on the call understands it is based off of what Medicare is paying. If it is under $1,000, it would be considered a widely available test.
Under $1,000 and over 100 providers, yes. And let me fix that typo, Alex, before you circulate slides.
Absolutely. And yep, thank you for the clarification. And we've got it on the recording for at least the call here. So I appreciate that. Cool. And we'll hold on the rest of the questions until after Anne's had a chance to speak. Oh, sorry, Anne. I think I went too far for you there.
Right, you're fine. Yep, I was moving, and so are you. So that's thank you so much, Erin. I have a bunch of notes I jotted down. I did want to remind everyone that at this point, SALSA has not passed, which Erin, again went through what it will look like if it does pass, and then kind of talked about the kind of some of the hurdles as far as with Congress and having them be available to move forward with passage. We've got a road for us. So PAMA is still in effect. And so again, we want to just make sure, there is some rules as far as your applicable labs. Again, you need to define whether or not you're an applicable lab. And if you are an applicable lab, you are required to report, and the data that you are required to report will be from the first quarter. Alex, my goodness, we don't have this on the slide, but it's January.
That's okay. January to March of next year.
Yeah, that's when we report. But the reporting, the data collection period it's really from 2019, right? It's January through June of 2019, correct?
That's correct.
So labs, if you were in operation or any group that is considered an applicable lab, you'll need to define that, and then you'll need to pull that data and submit by the beginning of next year. So we are available to assist with that if you are needing assistance or guidance and where you submit that information, communication to billing on how to pull the information, what Medicare is looking for that submission. Again, the first step, though, is certainly defining whether or not it is applicable for you at this time under PAMA. What I see with the SALSA is it does allow for I think, better applicability for the applicable lab. And what I kind of jotted down, Erin, I don't know if you want to kind of comment on this. Redefining applicability will really redefine the applicable data and price cuts. And so I want the group on this call to understand, again, the way that PAMA is written. You're pulling data from insurance plans that are paying, non-Medicare. So if some of these labs and some of these laboratories that are accepting well less than Medicare, that's really what's being represented. And so redefining that applicability will hopefully really give a better picture of what testing is getting reimbursed from other payers. Would you agree, Erin?
That's exactly right. And that was really the hope in drafting SALSA, was to specifically mention that the intention of the bill is to include the entire laboratory industry and not just some of those high volume, maybe lower cost tests. And so actually mentioning hospital labs, independent labs, and physician office labs in the bill is different than PAMA. And so, yes, I very much agree.
And then that has been, I think, one of the major arguments against PAMA is just there hasn't been a good representative sample. And so, we're not considering, again, the hospital labs where they're potentially getting better contracts. And so that is a good move. And again, just trying to define the applicable labs through PAMA, I think is challenging. So I did like that they're allowing for the test. If it's paid under $1,000, that's I think an easier way to define versus the way PAMA currently is written. All right. I was asked to kind of come up with a conclusion, and my thought is that labs are seeing continual cuts. PAMA is nothing new. We saw a pause because of the pandemic, which was beneficial. But we're constantly getting inundated with new legislation. No surprises went into effect the beginning of this year. That's another impact to reimbursement. We've got the PAMA and SALSA will help support, or I would say better support the laboratories in as far as potential cuts. But cuts are coming. I mean, that's inevitable. There's challenges with payer policy and again making sure that your testing is considered medically necessary. So you're pulled in many directions, and so one of the things that I always like to offer is some suggestions to, what do labs do? There's lots of different things you're being inundated with when it comes to reimbursement, and so really what my guidance would be is certainly understand what your reimbursement is by payer, by CPT code. How are you? How do you have contracts with payers? And are you making sure that what you are supposed to get paid, you are getting paid? If you don't have a contract with a payer, are you getting paid out of network? These are all things that most likely you will have to end up submitting to Medicare for them to define, again, that reimbursement. And if you don't know what you're getting paid, it's difficult to, again, advocate for yourself if there isn't visibility into that data. And then planning for yearly cuts. So we know that there's potential for yearly cuts going into place. This will happen the beginning of next year, whether it's through PAMA or whether it's SALSA. There is potential cuts to the clinical lab fee schedule. So how do you plan for that? And again, having visibility into your data really helps you understand and be able to forecast where those cuts are and what the lab will need to do to again, strategize and have a growth strategy. And I just, thinking ahead, planning ahead, don't be the grasshopper. Don't play in the summer. Prepare for the fall. Winter is coming. I just watched Game of Thrones yesterday, the new one. So we need to be again understanding that cuts are coming, whether it is through PAMA or SALSA. There are going to be areas of opportunity in your workflow process. How tight is your workflow? What is being, are all charges being captured? Again, going back to that reimbursement, are you getting paid on everything you should be paid, and are they paying the correct rate? Looking at denials, where are there opportunities for denials to, again, fix on the front end so you're avoiding denials, and making sure you're maximizing reimbursement. Again, on that front end, when you submit a claim, is it clean, and are you getting paid what you should be getting paid? Advocacy. So Erin's been on from NYLA, which again, I wrote down, Erin, the loudest voice gets the most attention. So it's important to advocate for yourselves. Make sure that you're partnering with groups like NYLA, with CAP, and making sure that your voice is being heard with the appropriate people that can make change and can put new legislation in action. All right, I think we can go to questions, Alex, if there's any questions.
Yeah, definitely. Just really quick, as Ann mentioned, I wanted to say we are available in case SALSA is not enacted to assist with PAMA reporting and just general, all the RCM guidance and best practices that Ann just covered. If you'd like to follow up with us, you may do so through that pop-out slide that just appeared on your screen, or follow up with us by email after the webinar. But thank you very much, both Ann and Erin. We're going to go ahead and address a few questions now. And Erin, I think you touched on this a little bit during your portion, but Mark is asking, what incentive would there be for Congress to pass this, SALSA, considering that PAMA right now is driving down CLFS rates so drastically?
Yeah, it's a great question. It's kind of the $1 million question. And I think a couple of things I'll say are, that's where our advocacy really comes in as important. Alone, Congress doesn't have any incentive to do this because you're right, it would be a cost to them. And so the incentive really comes from hearing from their constituents that this is important to you all and that this is unsustainable for your business. Constituents drive Congress because without you all, they're not going to get reelected. And so we have to kind of remember that basics of politics, that the House is up for election every 2 years. And so their goal is really to, listen to constituents, and you're exactly right, the squeaky wheel gets the grease. And so the more people who are commenting, the more people who are weighing in, the more likely we are to get this passed. And so our goal is really co-sponsors for the bill, and to try to show leadership in the House and the Senate that this is a priority for their constituents. So alone, maybe they have less incentive, but with all of our voices talking about how important it is, it becomes much more important to them to solve a problem. And somebody else further down in the questions talks about inflation, and this is certainly one of the arguments that we're using on the Hill. Independently of us talking about it, Congress doesn't have a lot of incentive to act on inflation, rising costs, et cetera, on their own. But those are key talking points that we've been using to talk to policymakers about this. So the increased cost of goods and services, the increased cost of labor, hiring people in labs, salaries going up, minimum wage being raised across a number of states. These are all things that we've been using to build that case to really to give Congress the incentive to do this.
Thanks, Erin. And then a little further down, we get a couple questions about whether or not there's a template email or letter to send right now. And I believe we discussed that before this call, but correct me if I'm wrong, if there is something currently circulating. And then aside just from even sending a letter, how can folks get involved on an individual level, aside just from engaging with organizations like NYLA or their lab?
Yeah, so those are really good questions, and there have been enough questions here, I think, about templates and the easiest way to send stuff. So we have talking points on the NILA website because we have been encouraging folks to make phone calls, but I'm happy to also provide a template email that folks can send, and we'll post that on the NILA website with those talking points. The letter will be ready next week, and that'll be published, that folks can use to send their own letters. I think in terms of getting involved, it really is through membership in a national organization, either that or through your lab, or certainly as an individual. So you don't need to get, you don't need to do it through your lab or do it through NILA. You as an individual can get involved in the political process. And there are a couple of other ways you can do that. Certainly, I mentioned members will be home for most of October campaigning. One of the things that they do as they head into election season is host town hall meetings. This is a way for them to connect with local constituents, hear from you all about all kinds of issues that might be impacting you, ask questions of them, put them on the spot a little bit. And so that's an opportunity as an individual where you can get involved and then certainly make your voice heard. You can also try to get meetings with your members of Congress as an individual. So you can do that in the district office, or you can request meetings when you call the DC office to connect with policy staff. Actually, since the COVID-19 pandemic, a lot of congressional staff are taking meetings virtually. So we used to have to travel, bring labs to Washington and travel if we needed to meet with them, but there are certainly opportunities now to have some of those meetings by phone call. So there are lots of opportunities. Certainly NILA tries its best to provide folks with the intel that they need to do that. We do trainings and things like that for our members to try to prepare them for those conversations, but anybody can do it. It is your right as a voter here in the US to have your voice be heard.
Very true. Thank you. And I think we'll close it out here with one final question. Jay asked that Erin touched on a little bit about the inflation, but Ann, I kind of wondered too, his second point that he brings up is this ever downward compounding effect of CMS reductions following reductions from private payers, who are in turn basing their rates off CMS allowables and then driving their rates down further when a PAMA happens or something like that, when they, base their Medicare bases its future rates off those private payer rates. Is this, it's sort of a snake eating its tail scenario here. Is this something that, clients express a lot of frustration about?
Absolutely. Because you're just getting inundated from all sides. And that's why I always advise that, if you have advocacy groups that can help support and help bring together the voices, it does, I think, long-term affect the industry. And if you're not speaking up, this will continue to happen. There's just very little protection over these types of cuts. And so, it's just continuing to make sure that you push back with the No Surprises Act being put in place. It's really, I think, removed any sort of leverage that we've had to try to negotiate or try to remain on a network. It's just that playbook has significantly changed as far as trying to negotiate with a payer. And so the same with PAMA and these cuts. It's just there's little leverage to change. And so the best that we can do is to continue to educate the appropriate people who can help pass legislation to protect some things on the importance of what you do.
Absolutely. All right. Unless there's anything else from either Ann or Erin, I think we're going to go ahead and wrap up here. Quickly, I just wanted to invite everyone to next month's webinar. We'll be discussing preparing your lab for monkeypox testing, our validation solutions, and then just an overall look at kind of the spread of monkeypox and kind of where things may be going. So please, if you're interested in that, go ahead and click that button and sign up, and we'll look forward to seeing you there. Otherwise, I want to say thank you again to both Erin and Ann. Very informative as always, and we greatly appreciate your time.
Thanks, Alex.
Thank you. Bye-bye.
Bye.